All right, hi everyone, and welcome to this webinar on an eclectic management of low back pain. So thank you so much for joining us this evening. It's really great to see everyone. I'm just going to start off with a little bit of an introduction first. So I'm Katie, and I'm the Training Education Manager here at Eclectic. So I have a clinical background in sports therapy. I've worked in private practice over the past 7 years now. My role here consists of planning and delivering all the virtual and physical events and basically exploring ways to maximise our education platform. So for those who don't know, I'm going to do a little bit of an introduction to the company as well. So Physical, we provide evidence-based medical technology and training. So we know that soft tissue management is a crucial part of rehabilitation, and we're always looking for that technology that can improve outcomes for patients and clinicians. So in today's webinar, we're going to explore a range of treatment modalities that can be used for treating lumbopelvic disorders. So the format will be a presentation from our guest speaker, followed by an interactive question and answer section. Just a little bit of housekeeping before we start. We're just going to ask you to please leave your microphones on mute just for the whole session, just in case any background noise, just to avoid this. Please feel free to share some of your videos. It's nice to see some faces on here. And if you do have any questions, please enter them on the chat feature. So you'll be able to find that just at the bottom of your screen. You can send in questions at any time, and we will just address these during the question and answer section later on. What might be quite useful is just to put question in front of the questions, just so that we can find them easy when we get to that. We also have Mary just working in the background here. She'll be managing a poll that we're going to be doing shortly. She's here generally just to make sure everything goes smoothly, and basically that I don't mess anything up. And just a reminder, the session is being recorded, so we'll make sure that we send a copy of the recording to you all within the next few days. So let me just introduce you to our guest speaker, Dr. Terry McGee. And Terry is the Director of Education of Johns Hopkins Hospital Rehabilitation Therapy Services and is an orthopaedic physical therapist specialising in persistent pain related to the spine. So we're really delighted to have Terry on with us today. He's going to share his expertise, especially around this topic. So before I do pass you over to Terry for the presentation, we are going to do a quick poll. So in a moment, you're going to see a pop-up on your screens. It's up there now. So the first question here is just to gather a little bit of background of you guys. So just click away here, give us a bit of an answer. And there is also a second question on there just to find out what percentage of your treatments that you do are for low back pain. So again, some just nice general information just to get us going with today's webinar. So we're just going to wait just a few more seconds, getting a few more answers in there, and we'll be ready to go. So again, just a few more minutes, hopefully, and we'll get some answers coming through. So hopefully it's popped up for everyone there that you can click on and answer. And we're just going to wait for a few more results to come through. All right, hopefully. Great, just a few more coming through now. So just really nice just to get a little bit of an idea of you guys, and especially just around the topic of low back pain today, and just see what your guys' answers are with regards to, yeah, how many treatments really are you seeing on low back pain and how often. All right, so I think we've got the results coming through now. So as you can see, we're just popping up on your screens, hopefully. So we have got the majority of you guys physios, sports therapists, massage therapists, some sports rehabilitators in there as well, perfect, and students. And the second question here, so what percentage of your treatments are for low back pain? And we've got a bit of a tie here. So we've got 26 to 50% and 51% to 75%. So So yeah, we're on the upper scale with regards to how many people actually do see who treat in for lower back pain. So thank you very much for engaging that. That's really good. And yeah, we are going to start now with the presentation. So Terry, if you're ready, I'm going to hand it over to you.
Great. Thank you very much, Katie. And I have to say good afternoon for me and good evening to all of you. It's really great to work with the team at PhysiQuip, and I'm very appreciative to have this opportunity to speak about something that's very passionate for me, and that's management of low back pain. And I throw in the idea of eclectic management because, you know, the way that I really try to engage my patients is such that it varies from patient to patient. I try to make my care very patient-centered and employ shared decision-making. So there's a multitude of, as we would like to say, tools in the toolbox that we can use. And I think that's the way we all need to, or my bias is that we all should approach low back pain. So just some quick objectives. You know, my hope is to really try to introduce the majority of you to some pitfalls that I see on a regular basis that clinicians tend to fall into, if you will. As many of you, I'm sure do, I wear many hats. And one of those hats is I'm the director of our orthopedic physical therapy residency. So very much in the same model that physicians go through residency and fellowship training. We have the same thing here in the States that is accredited by the American Board of Physical Therapy Residency and Fellowship Education. And we see these novice clinicians come in and very commonly, whether it's due to poor subjective or poor objective testing or even interpretation that lends to a poor outcome for the patient. And unfortunately, for some patients, becoming disenfranchised with what physiotherapists, physical therapists can provide. Also want to kind of look at the, you know, what is the current best evidence? Now, in the confines of this webinar, obviously, to talk about the current best evidence associated with low back pain, that could be a week-long course. So we're going to be very quick about, you know, what we're going to look at, and in particular, what I'm going to focus on is what we use here in my home environment at Johns Hopkins, and what we teach to our residents is utilizing the Academy of Orthopedic Physical Therapy's clinical practice guidelines to managing low back pain. And then lastly, I'm going to throw it all together kind of in a mixing pot and just give you some options to think about of how you can use pain neuroscience education, how you can use modalities, and most importantly, as a fellowship trained manual therapist, how we can use these to impart change in our patients' lives. Just a quick statement of intent, or maybe even a disclosure. You know, this webinar obviously is not meant to be the end-all be-all of treatment for low back pain. You all are all very highly successful physiotherapists, physicians, osteopaths, and I saw there were some students in there, so you're learning your way around how to manage what I would classify really as an epidemic rather than a diagnosis. But just to realize that this is just the approach that I take, that I like to teach with our residents, and even share with the medical community. And then, you know, really most importantly is that adherence is not going to guarantee an outcome, right? There's always that one variable that we cannot change, or we hope to impart change, but it's the patient. So, you know, every patient is different. So my approach will vary from patient to patient. So before the rest of you logged on, I was just chatting with Katie a little bit, and you know, my hope was to pass on this presentation much sooner than delivering it right now. But I had a little curveball thrown my way, and that curveball was the fact that one of my colleagues sent me an article that was just published in JAMA under their orthopedics, and it really reminded me that you know, we really need to change the game when it comes to low back pain. You know, we're kind of behind the proverbial 8-ball, or the deck is stacked against us. And what I mean by that are things like this. I'm a self-proclaimed golf hack. I was telling Katie I'm going golfing later today, try to get 9 holes in before it gets too dark. But it's these kind of things that really make managing our patients a challenge. You know, when somebody as high profile as a Tiger Woods comes out and says, my sacrum went out, it pinched the nerve and hence the spasm. And once that bone was put back in, good God, that bone needed to be put back in. You know, in my mind, that's telling me surgical fixation is the only treatment, the only remedy. And those kinds of words are very, very harmful. And we're seeing that more and more come out in the pain literature, and some of the individuals out there who are so much more significantly smarter than I am, and the Lorimer Mosleys and the Adrian Laus, and the way that the research that they do and the way that they are able to package up that research and de-escalate you know, the thoughts, the maladaptive behaviors that our patients might be experiencing. You know, I don't know if I'm just technologically challenged, but unfortunately this video wouldn't play, but I highly encourage all of you to go onto YouTube, Google Dr. Oz and low back pain, and you will find this video. It's pretty powerful on someone as high profile as Dr. Oz, who by trade is a cardiologist, talking about low back pain. So it's kind of like one of those stay in your lanes that would be very helpful. But what he has here in this cylinder are stacked jelly donuts with a disc in between. And he's telling this individual, who just happens to be an RN, that this is what happens to your spine when you sit all day. And he takes the plunger and he pushes down on the jelly donuts, and all the jelly squirts out. So here we have this very high profile physician talking about in a very negative way what happens to our spines when we sit for too long. And we all know that, you know, the latest catchphrase is really sitting is the new smoking, right? And we know that with our patients, we want to advocate for them to move, to undo postures that they're doing to themselves. Even at this very time, I'm kind of hunched over looking at a small monitor on my laptop. But I know I'm going to be up and moving around in less than an hour. I've said this many times to my patients. It's kind of like, you know, it's a catchphrase that here in the States, and maybe it's popular elsewhere too, that physical therapists use, and that's motion is lotion. And I would pay somebody to come up with something that's less hokey. But that's the one that seems to stick and resonate with our patients, that getting up and moving, and that movement is good, and it can actually decrease perceived threat. And that's what these types of videos teach our patients, is threat. It teaches them, you know, all of the negative things that can happen. And it's very, very graphic. So just a quick slide on those kinds of words, the words that hurt or that harm, that we want to try to do away with, that pathoanatomic approach to care, and how that has contributed to vastly the mismanagement of patients with low back pain. So here was the article that my colleague shared with me, the effects of spinal manipulation mobilization therapies in young adults with mild to moderate chronic low back pain. Okay, you think no big deal, right? We're looking at manipulation and mobilization techniques in patients that have mild to moderate persistent pain. But there's a problem in the title in itself, and that's the fact that it's persistent pain or chronic pain. And then you look at their control. Well, what was their control? It was a sham cold laser. Now, these three techniques, or the laser in itself, might be something worthwhile integrating into clinical practice. A patient may have had it in the past and had expressed to you on that first visit, when I saw Jane used a laser thingy on me and I felt great. Well, I may not be somebody who believes that the evidence is there quite yet to support the use of laser, but because it had such a powerful effect on my patient, I am surely going to integrate that into their plan of care. Spinal mobilization, spinal manipulation, you know, they're both tools that we utilize. And based on patient's presentation, based on their irritability, I might choose one over the other. But I would never choose any one of these in isolation. It is not pragmatic. It's just not how we approach care. There are outcomes, looking at a pain rating scale and then the Roland-Marsh disability questionnaire. Totally fine with that. We utilize patient-reported outcomes here in a clinical setting at Hopkins. We monitor pain, although we try to discourage perseverating about their pain, but we do, from a compliance standpoint, always ask about their pain. So when we look down at the breakdown of the individuals, it's pretty evenly split, 54 manipulation, 54 mobilization, 54 received the placebo. The inclusion criteria, the real big thing I wanted to focus on here was, if you're familiar with the work of Flynn et al., and looking at a clinical prediction rule for utilizing or finding patients that might benefit from lumbar regional manipulation, they found 4 factors that really not guaranteed success, but when all of them were met, the likelihood of success was extremely high. So looking at a patient, these patients didn't have symptoms distal to the knee. Their FABQ score was less than 19. They had the presence of 1 hypomobile segment, and they were able to rule out hip pathology with this idea that hip internal range of motion was at least 35 degrees. So when we look at their baseline characteristics, I think it's really important to note that the fact that these individuals, if you take an aggregate, they were clinically depressed. They had moderate kinesiophobia, and they had low disability. And why is that important? That's important because the interventions that they chose to measure in this study aren't appropriately matched for their patient characteristics, in my opinion. So study limitations, not pragmatic, right? We're not just going to have a patient come in and manipulate them or mobilize them and send them on their way. The idea of utilizing mobilization or manipulation is that the patient has what I would refer to as a mobility deficit. And if they have a mobility deficit and you give them mobility, you need to train them then to work in that new range of motion. So yeah, this idea of a mismatched intervention, the wrong primary impairment, in my opinion here, given the fact that they had maladaptive behaviors, they were fear avoidant, based on the Tampa Kinesiophobia Scale, although their FABQ didn't reflect it, that the Tampa score did, they provided the wrong treatments at the wrong time, and I'll get more into that. So when I work with our residents here at Hopkins, we talk about this idea of pitfalls, and I think this is a nice follow-up from where we were with that article. And the big thing that we see is with newer clinicians is just an absence of interviewing skills. And I'm going to kind of move very quickly through these for the sake of time and jump into some ideas of how we all can get a subjective or interview our patients better. Imprecise motor skills leads to inaccurate examination, an inability to analyze movement or even alter it. We think about a patient who might have patellofemoral pain and standing, going from sit to stand. Well, what happens if they turn on their glutes during that transitional movement? Does that alleviate pain? Deficient interpretation of those subjective and physical exams. And that's where they have an inability to match the right intervention to the primary impairment. So they select the wrong physical impairments. They have poor mastery of motor skills. So even their passive treatments, their manual therapy skills, don't impart significant change, or even worse, irritate the patient, not them personally, but maybe their symptoms. And then, and this is a big part of it, is poor mastery of patient education and counseling skills. And that's where, where we have those patients with the maladaptive behaviors, where our pain neuroscience education comes into play, and knowing when and which patients to provide that type of education to is profoundly important. So the ultimate outcome to falling into any one of these or multiple would be care received is markedly less optimal. Right? The patient has a poor outcome, potentially stops coming to practice or to the clinic because there's not good buy-in, because they're not seeing significant change in their life. So how do we fix that? To me, it all starts with the patient interview. And I think over my clinical practice, and I've been doing this for over 20 years now, and I have gone through significant changes just from my own residency and fellowship training, where I have found that I get the most information from just sitting down and listening, affirming, reflecting, and summarizing what the patient has told me. It engages them, it motivates them, and it gives me enough data to be able to guide my then examination and ultimately treatment. So what we like to do then is talk or utilize a concept of motivational interviewing. So what is MI? MI is a collaborative, goal-oriented style of communication. So what we're trying to do is just engage the patient to a point where they are doing all the talking, and we can just sit there and be active listeners. And that active listening promotes an environment of acceptance and compassion. And that is in my my practice, it's extremely appreciated by the patient, because often they'll come in and say that nobody has ever listened to me like that before, because they had a lot. They just, sometimes it's word vomit and we need to rein them in, and that's totally fine. But a fair amount of times, either they've been written off as kind of failed conservative treatment, or they just haven't been able to tell their story to the extent that they wanted to. So when we look at the underlying premise, it's this idea of collaboration, compassion, acceptance, and evocation. And those interlocking circles are the spirit of motivational interviewing. So there's 4 key skills that we utilize when we do our history, and it's subjective. It's a nice acronym, and it's OARS. So open-ended questions, affirmations, reflective listening, and summarizing. So we all know what open-ended questions are. We invite the person to reflect and elaborate, and we do that by using STEM words like how, what, where, or why. We try to avoid closed-ended questions. How are you feeling today, Andy? That's not what we want to say, because it allows for, in this case, I'm picking on Andy, for him to just say, fine. And that doesn't give me very much information, and it actually closes off the patient to want to express more. So we want to think about, how can we engage the patient more, and use words and phrases that draw them out. And comment on those particular strengths and abilities or good intentions and efforts. If your patient is telling you that they love to get out and walk, and that walking feels better, we want to affirm that. We want to tell them during the interview process, I think it's great that you get out and walk. And it empowers them to do, rather than fostering dependence. So it's just a way of thinking, finding what is right rather than what is wrong. And the ultimate outcome, yes, we want to facilitate retention and self-efficacy, their confidence, but we want to have positive outcomes. I like to joke with my patients that it's all about me. It makes me feel good to know that they're feeling good. So reflective listening. We want to make statement that make a guess about the client's meaning, because if you reflect on what they're telling you, and you say something along the lines that it sounds like your work environment is very stressful, it lends to their ability to tell you more about how being in a stressful environment affects their pain. And it then empowers you to make meaningful clinical decisions to develop their plan of care, to maybe give them strategies to handle the stressors at work better. So it deepens our understanding, and it's a way of checking your guess rather than making false assumptions. So good reflective listening tends to keep the person talking, and the more I can keep them talking in a productive manner, the better. Like I said, I think that really fosters a therapeutic alliance with the patient. It helps me gather as much data as I can, and it allows for them to feel like I am an active listener, I'm actively engaged in this process, and that I am 100% here for them. One of the other challenges that we have is electronic medical records, and the requirement is that we provide point of care documentation, and that could be something that some people are very good at, and then others like myself are still a little bit old school. What I tend to do is I write everything rather than typing away. And I'm a pretty proficient typer, but I feel like I have a level of OCD that kicks in when I'm typing, and I start making corrections to typos. And I'm more concerned about what's happening on my computer rather than engaging and maintaining eye contact and active listening with my patient. So that's just an aside. So good reflective listening tends to move the discussion forward also, rather than the person just repeating over and over again things that they have said. Move right along here. And then summarizing, right? Essentially bulk reflections. Collect what the patient has said and offer it back to them. And I'll say to them at the end of my subjective, I say, if you don't mind, I'd like to provide a summary of everything that you just said so that I can make sure I have your story correct. And then I allow them to interject and correct me just in case I have something wrong. I might have something out of order. I might have a date wrong. They might want to elaborate more about a significant event that contributed to the onset of their pain. And I want to provide them that opportunity. Again, more data collected for me to better tailor my exam and then ultimately develop a plan of care and treatment. Now, the challenge with a patient that I noted before in providing that education, that pain neuroscience education, is not every patient is ready to hear it. And this is a common mistake that we see with our new grads and our residents too, is that they really want to hone this message of of hurt versus harm, and use different analogies or metaphors to really explain to the patient that movement is good and that they will get better, that their spine is inherently strong. However, it's important that we understand where the patient is in their readiness for change. Not every patient is ready to hear the pain message. I've had the pleasure of seeing Lorimer Mosley in person at courses, at conferences, and just the way that he is able to talk about providing the patient a nugget and how that nugget needs to be just that small. and he talks about it in a way where that nugget is put in their pocket, and they leave the clinic and they're going about their business, and they reach into their pocket for some reason or another, and they're like, oh, what is that? And they pull it out, and that nugget is, something along the lines of hurt versus harm. And it allows for them to have a period of reflection and to realize that, I might hurt, but that doesn't mean I caused damage. But not every patient is ready to hear that message right from the beginning. Okay, so as we go through with our training of our residents or in my clinical practice, the idea, like I said, of a really stout subjective or history, trying to employ the concepts of motivational interviewing, using those ORs to their fullest. And then what I do is I place my patient into a bucket. And sometimes they fall into multiple buckets, and it's my job then to really decipher their story and tailor my exam to understand which is the primary impairment. So when we look at the clinical practice guideline for low back pain, the first thing that I try to do with each and every patient of mine is I want to stratify them according to risk. And that risk is, are they at risk for going on to persistent pain? Lower risk patients, we can be very quick with our treatment. We can give them advice and education, and we don't need to spend a lot of time with them. I like to tell my patients that you have better things to do with your life than hang out with me. We have great conversations, but at the same time, I want to empower them to not be reliant on care that I provide. Rather, I want to give them the tools to manage and get better on their own. And that affords me the ability to get more patients in. I know it's kind of a counterintuitive model, but I don't want to do or have sessions with my patients for weeks on end. I really want to try to empower them and get them out and moving and doing and maximize the care that I provide in the clinic. And this risk stratification is done by utilizing the Keel Startback tool. And that's something that we have built into our EMR so that we can get that data right on day one when the patient logs or checks in. So from there, after I've done my history, what I'm trying to figure out is, are they somebody with mobility deficits, with motor coordination impairments? Do they have related or referred lower extremity pain, radiating pain, or related cognitive affective tendencies, or generalized pain? So with mobility deficits, this is where we're going to jump in and we can be, I don't want to say aggressive, but we can really try to impart quick change by utilizing a high velocity, low amplitude thrust. In this study by Flynn et al., this is the one I was talking about earlier, the variables of duration of symptoms of less than 16 days, no symptoms distal to the knee, lumbar hypermobility, ruling out hip, and then the fear avoidance belief questionnaire of less than 19. So there were subsequent studies done. The sweet spot with this really is, 4 or more of these predictors being present, and it increases the likelihood of success, and success being measured by a 50% reduction on their oswestries. It was 95% success rate. If you look at a pragmatic rule, which was done several years later by Fritz et al., what they found that 2 factors really stood out, and that was symptoms distal to the duration less than 16 days, and then those symptoms distal to the knee. Now, looking at this study, what they did was they did the painful side first. If they didn't cavitate, they repositioned them, performed a thrust again. If it didn't cavitate, then they positioned the non-painful side to perform the same technique and in that same fashion. And then they went into active range of motion exercises. And the reason I emphasize that is because, you gave the patient mobility. So now you want them to move in that new range. But additional studies have shown that that technique is not necessary to achieve the same outcome. So this is just a different one that I utilize. Still kind of a lumbopelvic regional manipulation. When I perform this, I can get multiple segments to cavitate, or I can use it to target strictly SIJ. And then we also see in the evidence that even a sideline gapping manipulation, looking at where the facets are literally just gapping, it's neutral. They tend to be very comfortable for the patient, but again, providing mobility when mobility is lacking. And then the other one to kind of consider is that there is evidence that there's no difference in pain when performing thoracic manipulation versus looking at a regional specific technique to the lumbar spine. So even treating patients who maybe are a little bit more irritable in the lumbar spine by addressing mobility deficits in the thoracic spine can also provide significant pain relief for our patients. When we look at movement coordination impairments, depending on irritability, and this is kind of a busy slide, but you can see on the left-hand side where their disability, or you might even want to say irritability, high, moderate, or low, really gives you an idea of how you can gauge activities to train the core to support the patient as they move through movements, not excessive movements. So there was attempts by Hicks in the past, as well as Raven, to look at the development of a clinical prediction rule for individuals who would benefit from stabilization. And Hicks looked at 4 variables in particular, and that was less than 40 years of age, an average straight leg raise of greater than 90 degrees, the presence of an aberrant motion. And to me, aberrant motions might be, somebody who does some thigh climbing, or maybe even knee flexion, transitioning from forward bend to fully upright. And then as far as a clinical test that by itself doesn't have high likelihood ratios of being a positive for ruling in a diagnosis, but coupled with this rule made it a lot stronger, was the prone instability test, where the patient is laying over the edge of the plinth and raising up their legs in full extension. And if the pain is present, then a P to A mobilization sustained is applied, and it is applied again. And what we see is the pain disappears or is reduced. So individuals, the more variables that they had present, what they found was that these individuals tended to benefit from lumbar stabilization. So in the validation study, unfortunately, they couldn't validate the rule, but the two or most predictive variables were the aberrant motion and the prone instability test. And these are ones that I use regular or I look for in clinical practice, as well as teach with our residents. So how do we intervene? And this is like the bread and butter of our clinical practice. This is tailoring the intervention or the exercise or neuromuscular re-education to what is most impactful for the patient. For individuals out there who really have found the work of someone like Paul Hodges or Shirley Sauerman to be beneficial, engaging transverse abdominis in different positions, and then gauging their disability or irritability and challenging them accordingly and moving through probably one of the most iconic exercises for core stabilization in something like a bird dog. But then we also have to think about, is this a functional task? And, I tell my patients all the time that there's nothing functional about them lying on a bed and engaging their abdominal muscles to start to wake up their core. We need to have them moving in and out of functional tasks, transitional movements, learning or relearning to use their hip joints to ensure that they can properly move and engage their core so that their pain can ultimately diminish and go away. When we look at pain going into the lower extremities, depending on their irritability, again, will determine how it will determine the vigor at which we want them to perform some of these exercises, whether it's against gravity or with gravity. But this is, if you're a McKenzie trained therapist, which I am not, but we kind of steal bits and pieces from McKenzie's philosophies, McKenzie's principles. And what we're looking at is repeated motions, right? We want to encourage a particular movement direction in order to foster centralization of their pain, and then give them support through daily life with something like a lumbar roll to further facilitate a decrease of pain and return to normal function. And then when we look at an individual with generalized pain, this is the individual who has high maladaptive behaviors. They're fear avoidant. They might catastrophize. They might have signs of, if not come positive or show positive for clinical depression. And our sole intent with individuals like this is that catchphrase that we use here in the States, and that's motion is lotion. We want to decrease threat, get them to move in what they perceive to be a safe environment, and allow for them to see that they can do things. And that brings me to some of my final points. So how do I integrate technology or modalities into my clinical practice to do this very thing, to decrease threat when a patient presents with those maladaptive behaviors or fear of movement or catastrophizing or hypervigilance, and where something like my hands performing even graded mobilizations, or if they're lower irritable but still fearful, doing something like a thrust mobilization or manipulation. And this is the cycle that I want to get them out of, right? I mean, we're going to experience pain, but I don't want them to catastrophize. I need them to confront eventually the movement that they are fearful of, so that they can recover. What's on the left-hand side is what I want to keep them out of or get them out of and moving into recovery. So one of the things that I utilize is dry needling. It's something that I'm trained in. My number one rule for not doing it would be an individual who has an aversion to needles. I mean, quite simply, if somebody does not like needles, and I know there's probably not too many people out there who are like, ooh, needles, I love needles. But most people will say, well, if I don't see them, I'm not going to mind. And they don't even feel them going in. But I can get down to the multifidi and the lumbar spine. I can apply a TENS unit, a probe stimulator is what I like to use. I can stimulate the multifidus. I can reduce pain that way. I can provide input into that segment, into the nervous tissue, and I can talk to them while it's going on about hurt versus harm and perceived threat. And then afterwards, get them to perform a movement, let's say it's forward bending, that they're fearful of, and do it in what they would perceive to be a safer environment, such as supine knees to chest. Very simple. I'm a big fan of soft tissue mobilization. I mean, ultimately, I would love to provide mobilization or manipulation to a lot of my patients, but not everybody would benefit from that. And quite frankly, it's not always indicated anyway. But performing soft tissue mobilization can be a very powerful tool to change a patient's perception about what's going on, because they can see what you're doing most times, and they can perceive the immediate effects afterwards. Muscles that I regularly target are ones like the iliacus or the psoas, although in this case, I'm going to make the assumption that's more iliacus, but that one is a big one I like to target. Quadratus lumborum is another one. I find it to be a major player in patients' pain. And then, of course, I can do the same thing along the multifidi and the paraspinals. And I'm not a very flexible person, so my thumbs allow me to do this. But obviously, for a lot of people, using an elbow or a fist and good body mechanics can really impart significant change on your patient. But in cases where I can't use my hands because my pressures are even more sensitive, one of the things that I find extremely helpful is in employing IASTM, so instrument-assisted soft tissue mobilization. And in the lumbar spine, there's different tools, different vendors that make tools. This one is a Hawk Grips number 9. I jokingly refer to it with my patients as my prison shank, but for fun. But that one I really like to be able to use to kind of frame around the spinous process, to get interspinous ligament to if you will, scrape around the pelvic gutter. And that really fosters nice change for the patient. It provides a stimulus into the nervous system that is non-threatening. I can change the direction of the bevel to make it more or less vigor, if you will. The companies will say that it can be desensitizing depending on the direction of the bevel. So I'm a big fan of utilizing IASTM in clinical practice with patients that are more towards that moderate to high irritability. And then for those patients that can't do that, a negative pressure device, whether it's cupping, or in this case, I am very blessed that my director really is passionate about incorporating technology into clinical practice. And all of our clinics have, in this case, this device, a LymphaTouch. And this is a great tool for myofascial release. I can have people perform mobilizations with movements. I'm kind of a self-proclaimed nerve nerd. So if I'm having a patient work on, performing a slider, and I'm trying to decrease the threat in the lower quarter, I can be using a device like this to work the container as a soft tissue mobilization as they are performing their slider. And it really has a nice effect on the patient's confidence and empowers them that they can move. And then the other thing that I'll do, whether it's, and I think taping is something where the evidence is still kind of building, but it's another tool to be able to decrease threat in our patients, to offload tissue from a biomechanical standpoint. And it's something that I'll regularly utilize in my clinical practice. And I base all these interventions truly on our patient's level of irritability and how they're presenting and what I'm able to glean from them from their subjective. So my key takeaway points, patient-centered care. That's such a profound point to make. And I'm positive each and every one of you are patient-centered in your approach. But developing that therapeutic alliance, the more your patient buys into what you are offering them, and that you are empowering them to make decisions in their care, the more positive the outcome is going to be. And then this is a big thing for me is identifying the right impairment providing the right treatment at the right time so that you can decrease that perceived threat. You can empower them to move. You can empower them to know that their spine is inherently strong, and that they will get better. And always remember, and this is something, I've done some of the training through the Titleist Performance Institute, which is just a matrix of being able to evaluate and work with golf hacks like myself. And one of the profound statements that they made in their coursework is, never bring a stability correction to a mobility problem. And that really has stuck with me. If you find somebody that needs stabilization, you provide them with stabilization. It doesn't mean they don't have mobility deficits in adjacent areas, and most definitely we want to address those. And then with our patients with mobility deficits, we want to provide them with range of motion, but not necessarily spend time on engaging core. And then always remember, find your patient's readiness for change, and that not every patient needs pain neuroscience education. So lastly, we want to empower our patients, and my goal is always to foster independence versus dependence on me. And I employ different modalities and technology in my clinical practice to try to make that happen. So that's my presentation. This is me, right? If you want to say anything at all, please feel free to reach out to me. You can connect through me through WhatsApp, through email here at Hopkins, my LinkedIn account, that's fine. LinkedIn is really the extent at which I do social media. I apologize for that. I guess it's just something I haven't taken to, but I'd love to field any questions or concerns that people have.
Thanks so much, Terry. Really, really great presentation there. Yeah, such a good insight. Definitely some useful points there to take away, especially in such a broad area. So yeah, really, really great. So we're going to have a bit of an opportunity for some question and answers, if that's okay. So guys, if you have any questions, please just pop them in the chat feature now. Don't be shy. Any question is a good question, and I'm sure Terry will definitely be able to help you guys out. So we did have a question submitted previously, actually, just about a recommended treatment length and the standard appointment time for treating lower back pain. So before we ask you, Terry, on this one, we are going to do another poll. And again, just to see what you guys have to say on this. So here it is now. So if you want to just quickly answer this question for us, and we can gather some answers. So how long is your standard appointment time? And just pick the nearest off that list, and we'll gather some results before we hand over to Terry to see what his thoughts are generally on that. So let's just wait a few moments and that'll come through. So here we go then. So yeah, so we've got there 45 minutes. You guys saying that that's generally the average time that you would spend on treating lower back, or just general treatment times. It is quite close, obviously ranging between the 30 minutes and the 60 minutes. So Terry, with regards to that question, what are your sort of general thoughts? What's your clinical experience with regards to treatment length and treating lower back?
Yeah, that's a great question. So here where we are, because of the environment that we're in today with COVID, social distancing being paramount, we have a pretty large clinic, but in order to provide the patients with the safest treatment room or treatment space that they can come into, all of our appointment lengths right now are 60 minutes. And that just allows for us to turn over each space, make sure it's wiped down appropriately, and then a lot of the types of antibacterial or disinfectants that we're using on our surfaces require actually up to 4 minutes to sit. So yeah, right now we're at 60 minutes, but our typical practice is 40-minute follow-up, 60-minute evals.
Yeah. Okay, great. Yeah, which is obviously what everyone else was sort of, what their feedback was on that as well. So that's great. So we have got some questions coming through now. So we've got a question from Angela. So hi, Angela. Angela says, hi, Terry. And what are your thoughts on focus shockwave and lower back pain?
Another great question. Thank you very much, Angela, and hi to you. You know, shockwave is one of those technologies that's really gaining favor. And again, my director being such a motivational force behind employing or incorporating technology into practice, we actually have shockwaves in each and every one of our clinics. And I think it's a great tool for me to be able to just change the stimulus that is coming into the patient and impart change for them. And a lot of these technologies where the evidence isn't quite there, it's still growing. You know, I think that's where that anecdotal evidence or case series, you know, can be very powerful. So, you know, individuals who are utilizing that on a regular basis and seeing change, I always encourage them to write those up so that, you know, we can learn more about that type of technology. But absolutely, I'm all in favor of it.
Great, thank you. So next question from Kenneth Ross. Kenneth says, brilliant presentation. Would you mind clarifying which muscles you treat with the Hawk grip in terms of pelvic gutter?
Yeah, so when my patient is in prone, you know, what I'm doing is coming in and I'm trying to get several things, really. If you think about thoracolumbar fascia and its attachment to the pelvis, I'm trying to stimulate that tissue. I'm trying to maybe even get close down to multifidi, depending on how irritable the patient is. Definitely, you know, your paraspinals are going to be stimulated, and even a little bit of QL if I can get deeper in and along the line of the ilium itself.
Great, thank you. And another question from Angela. Do you use DUS as a rehab tool for transab and multifidus rehab?
Yeah, that is something where I am like in and out of. I mean, ultrasound is such a powerful tool, and for your patient to be able to see them actually engage transverses and keep oblique as quiet as possible can be super beneficial. Where I struggle myself, and this is my limitation and something I need to be better at, but is just taking them from hook lying, excuse me, or supine, however, you know, you're performing it, and getting them into different positions. And that's where something like the diagnostic ultrasound, the gel, the sound head, I'm just not as, I get to be a little bit of all thumbs, and I'm not as accurate with my retraining during that time if they're doing functional tasks.
Right. Okay. So we have next question from Vincent. Vincent says, hi, Terry. How much do you intake SI joint issues when treating lower back pain?
Yeah, you know, SI joint's one of those ones that really, you have some of the old school guys like myself who have been trained by individuals who are firm believers in SI joint dysfunction, regardless of age. There are case studies out there looking at individuals, you know, in their 70s who had techniques, manual therapy techniques directed at the SI joint, decreased pain, decreased disability, return to prior level of function. So I am still one of those individuals that believes that the SI joint can be problematic for patients, and that I do treat those. How often I see them, I mean, it's kind of a mixed bag. I'd say right now, if I had to give it a label of patients, I have a lot of COVID backs because the vast majority of people have been working from home in poor ergonomic settings, and they just have these general non-specific low back pains.
Would you generally sort of assess the SIJ joint whilst you're doing the lower back assessment on each time, or is that something just per patient?
No, another great question. I do. And the problem with the SI is that from a movement standpoint, those tests have some of the poorest likelihood ratios, and even a cluster of tests, it's not reproducible, and individuals who have studied SIJ test, they're the ones who then speak the loudest and say, you really shouldn't be assessing it. However, what I do use are provocation tests, and Laslet's work looking at different provocation tests for the SI joint to me are a really good predictor of whether or not the SIJ can be implicated. So I'm definitely, what I like to say is I believe everything kind of starts from the pelvis, and then it either moves above or below from there.
Okay, great, really useful. And we have a question from Khalid. So what is the most important to decreasing or preventing non-specific lower back pain?
I'd say the biggest thing is keeping people active. And you really need to think about, especially something like non-specific low back pain, as being an exacerbating and remitting disorder. And what I mean by that is it's going to come and go. And there are contextual factors in everybody's life that unfortunately are going to facilitate the comings and goings. And when life kind of starts to take over, that's when those patients start to lose the ability to manage, and they might start being less active. They might be not as successful in handling stress in their life, whether it's at home or at work. And they might start doing other things like eating or sitting more, and that loss of activity we really see fosters some more of those poorer outcomes associated with low back pain.
Great, thank you. So we think we've just got time for one more question. If we haven't answered your question, obviously we'll get back in touch and we can send them over by email. So again, Angela has just said, how many treatment sessions on average do you need to discharge your back pain patient?
If it's an acute back pain patient, first episode, I would say it's going to be on a low end. I've had some two visits, and they're pretty much right as rain, because you can identify and target a segment or multiple segments, provide them with the mobility that they need with a high velocity, low amplitude thrust, and they're pretty happy after that. You go to the other extreme with somebody who has persistent pain that might wax and wane. It could be anywhere upwards to, say, 12 sessions with them. And then what I tend to do with them is really try to push them out and empower them with the home program that we developed, and always serve as a resource. But on average, I would say my probably average number, small range, would be 5 to 7 visits.
Great, thank you so much, Terry. So
sure.
We're going to end the questions there. So thank you guys for entering those questions, and thank you, Terry, for answering. Yeah, you're definitely an expert on this. So really, really good and really useful points. So yeah, we're going to close up now. So I just want to say thank you all for joining us this evening and your participation. So we've really enjoyed having Terry here, and we've enjoyed you guys logging on with us. So following this, you will receive a survey along with the link to the webinar recording. So we'd really appreciate just any feedback that you do have and suggestions on any further webinars. So Terry, could you just flick along to the next slide for me? We are running another webinar next Thursday evening, as you can see there, the biomechanical approach to neck pain and how this impacts treatment. So this is going to be with a guest speaker called Natalie Perkins. So if you are interested, come along. Again, the recording is available, so you can still register and we can send that to you afterwards. So please just visit our events page as well. We've got loads of webinars coming up. So please just take a look at that webpage and sign up to any that you're interested in. Again, we've mentioned just on that slide, we're running a competition to win a Hope script. So Terry, yeah, you mentioned your Hope grips and you're using them. So if you guys are interested in that and you want to have a chance to win one, so all you need to do is just enter a survey, and we can send this out to you guys again by email afterwards. If you are interested in anything that we have mentioned sort of through the webinar today, any of the technology or any other questions that you do have, again, please just send us a message at info@physiequip.com, and we'll be more than happy to answer those questions and give you some further information. Mary has just put the survey link on the chat, so if you want to quickly grab that and have a look at the survey, then please feel free to. So otherwise, thank you so much. It's been really great. Thank you again, Terry, for your time. It's been really great working with you, and yeah, we'll hopefully do something again soon.
That would be great.
Great. Thank you so much, guys. Have a nice evening and take care.